My name is Rafael de la Hoz. I'm a professor in the Department of Environmental Medicine and Public Health and Medicine and the Division of Occupational Medicine at the Icahn School of Medicine at Mount Sinai here in New York. And I was asked to talk about, present an overview of occupational lung diseases. All right, have no relevant financial conflict of interest to disclose. And in this overview, I'll try to describe the major types of occupational lung diseases. Of course, this is a very broad topic, and but at least I'll give an idea of some of the general principles, and I sent some further reading to the coordinator so that is available to those attending. I'll describe the clinical approach to the diagnosis of occupational lung diseases and describe how this approach to treatment of these diseases differs in any ways from that of the non-occupational counterparts. So just to present the historical perspective very briefly, going back to antiquity, there were descriptions of trade-related diseases, even back to Hippocrates and Galen. And there was perhaps the first acknowledged reference to occupational lung diseases was what was called Miner's thesis in Georg Bauer treatise of the metallic arts. That's what that translates. That was a book. And in 1567, the so-called father of toxicology, Paracelsus, also wrote on similar issues. But perhaps he acknowledged seminal work in occupational respiratory diseases was the treatise of Bernardino Ramazzini in Italy of this book that was considered the first occupational medicine textbook. And during the Enlightenment, the encyclopedias included many references to these diseases from occupation. So in a number of factory acts in Great Britain during Victorian era in particular, there were mentions to these occupational diseases, and in the late 1800s, they saw the development of workers' compensation systems in the main industrialized countries. In the United States, it proceeded state by state from 1911, and curiously enough, Mississippi was the first one to 1948 in the USA. And in 1969, the first specifically occupational lung disease law, the Coal Mining Health and Safety Act, which is still in place, it was enacted in the United States. So, and then after that, for about 15 years, there were a large number of laws that were enacted both for the environment and for occupational regulation. They are just listed here, concluding in 1986 with the Asbestos Hazard Emergency Response Act, when it was recognized finally that asbestos was indeed a cause of occupational diseases. So I want to just review some general principles, that overarching principles for occupational and environmentally induced lung diseases. Toxic exposure may cause virtually every major clinical form of respiratory disease. So almost any defined lung disease may have an environmental cause. Few environmental lung diseases will present with obvious pathognomonic features, and I'll review some of them just so you get a sense of some of those diseases that have idiosyncratic features, but the others do not differ from the non-environmentally determined counterparts. Now, the chronic sequela of a given exposure cannot be predicted from the acute effects. That's another important truism in this specialty. The acute and chronic effect of a given agent may be caused by entirely different mechanisms, and some of them are only partially understood. Now, for acute diseases, there is usually a short and predictable time period between exposure and the resulting clinical manifestations that should suggest that such an association. But for chronic diseases, long latency between the first exposure and subsequent clinical manifestations is common. And that's why it is important in occupational, in obtaining an occupational history to really try to go back to the first years of employment to past occupations where the exposure that may have determined the disease that is presently being investigated in a particular patient may be related to. And an important thing is that although we try to obtain some idea what the exposure dose was, that exposure dose may determine the severity of the disease in an individual patient, the incidence of disease among several individuals that were exposed, or the rapidity of the onset, but not necessarily all three. So you shouldn't expect that all three are going to be determined, but you still need to get some sense of what the intensity of the exposure was, even if it is just quantitatively, non-quantitatively. So all environmentally induced lung diseases are preventable, and that's the reason why it is important to identify them. And however, some chronic diseases may progress despite curtailment of the exposure to the offending agent. So sometimes when they are diagnosed, it may be already too late. But it is still important because you will still be preventing disease in other individuals who may work in the same environment. Individual differences in susceptibility to exposures exist, and that is, you are going to see it through your pulmonary series, that with any lung toxin, for example, tobacco is a great example of that, not everyone is susceptible to the effects of tobacco. Everybody has a grandfather who was a chain smoker and never developed clinical lung disease. And the same happens with many of the occupational agents. Host susceptibility remains to be explained. Is actually rather poorly understood despite intense investigations, but it is likely to include both genetic and epigenetic and other acquired factors. As I said, very poorly understood. The importance of making a diagnosis of occupational lung disease is that it affects treatment and prognosis of an individual patient, has some legal and financial implications for the individual patient, and it helps identify a larger population at risk. So, and you know, and in a larger perspective, it also contributes to research to disease type, because in and of itself, these diseases end up being live experiments in the causation of a particular disease. So there are many classifications of occupational lung diseases. I'm just presenting a very brief and one, but it's just to underscore the fact that almost every type, every major pattern of lung disease that you are going to hear to your series can be caused by an occupational agent. So here we have chronic airway diseases, including asthma, chronic bronchitis, chronic obstructive pulmonary disease, parenchymal diseases, pneumonitis, and alveolar disorders, and it can be ARDS, pulmonary alveolar lipoproteinosis, interstitial lung diseases, a large group of diseases that includes several occupational and environmentally determined ones. Lung cancer, going all the way to malignancies, and pleural diseases, either benign or malignant. So as all what I wanted you to appreciate was that virtually every major pattern of lung disease can have an occupational cause, and that is the reason why in your differential diagnosis, you need to include that as a possibility and try to obtain in your past medical history an occupational history. So The clinical approach to occupational lung diseases can be summarized as three major points. One, there is first a physiopathologic evaluation and characterization of signs and symptoms, as you would do with any potential respiratory disease. Then you try to establish the etiology. And in the case of, if you are thinking of occupational one, you try to review all potential exposures, document those that may be most relevant, and assess the biological plausibility in terms of getting an idea of what the dose may have been, of that the latency may have been, and other associated phenomena. And of course, reasonably exclude competing causes, because in those differential diagnoses, as you well know, there are several diseases to include. So in the evaluation of exposures, you start by obtaining a complete job and exposure history. So you both ask the type of jobs that the person may have performed, and ask the person if they were exposed to vapors, dust, gases, fumes, and that mnemonic VGDF, vapors, gas, dust, and fumes, I think is helpful to the generalist to really try to elicit a history of some potential exposures from the individual patients. There can be a review of what are called the material safety data sheets, which every employee in the United States is entitled to being able to obtain. You, as a physician, actually can request those safety data sheets from the hospital where you work. Just to give you an idea, you are no exception to this law. You try to get a sense of the epidemiologic pattern. When the symptoms get worse during the week and better when away from work, whether there are other workers in the environment that may be similarly affected. You try to see if there's a possibility of performing a workplace evaluation, and usually this is done by the occupational specialist, sometimes with industrial hygienists, to try to get a sense of that, and obtain health records from employer or from the union, data from OSHA inspections, because these are public documents, so they are available upon request from everyone, and particularly physicians, and markers of exposure in clinical material if it is possible for some of these. One important consideration that I wanted to get out, if I don't say anything through this talk, is the importance of keeping this scheme of a hierarchy of occupational exposure control measures. And just to underscore the fact that, unlike what most people think about personal protective equipment, those are the lowest priorities and the least effective methods to control for exposures. The best one is the elimination, if at all possible, of the hazard. The lower level is what is called substitution. So if there is a material that is hazardous, you try to find one that can be substituted, and try to that way mitigate the potential hazard of the first one. Hopefully the second one doesn't pose any additional or similar hazards as it sometimes happened in the past. The next level of exposure control is what's called engineering controls, and those are related to ventilation, different types of devices to, for example, using wet methods when there is a very dusty environment. The next one is administrative controls, rotations, isolation measures, for example, in the hospital. And as I said, the last one is personal protective equipment, because it is very difficult to next to impossible in the presence of a hazardous situation. First, to have complete safety with mask and other devices, but also to make a worker wear them continuously during the entire shift and every day at work. So this hierarchy of exposure controls applies to virtually every occupational disease, not just respiratory. I also wanted to mention that some of the aspects that I have discussed pertain to specialists in occupational medicine. In the state of New York, there is a Department of Health, New York State Department of Health Occupational Clinic Network. Has about 8 or 9 different clinics, and you can find out about them in the Department of Health website, and that's their telephone as well. And at the national level, there is an association of occupational and environmental clinics, most of which are based at academic centers, and it's AOEC, and you can find it again at their webpage. And just so you know, at the very local level, at your hospital, in Staten Island, there is, Mount Sinai has a center for occupational health, and it's actually a joint venture with Richmond University Medical Center. So just so this contact information is there. So there's always a way to have a resource nearby practice. So work-related asthma is, I'm going to present some examples of occupational respiratory diseases, and this is considered the most frequent occupational respiratory diseases in the developed countries. And as you know, asthma develop from an interaction between host factors, most likely genetically determined, and environmental factors that may be non-occupational, like pollen and different allergens, and some of them are completely unknown, and occupational factors. And then they drive an inflammatory process in the airway that has a certain number of characteristics. It has allergic pathways, T lymphocyte activated mechanisms that eventually lead to the structural and functional changes that make asthma recognizable. They are listed here. They are very well documented. And the functional changes in lung functions, such as classic reversible airway obstruction and bronchial hyperreactivity, that interact amongst themselves and produce the symptoms of the patient. So the same happens, of course, with the occupational diseases. So it's no surprise that occupational asthma clinically is very similar to non-occupational asthma. This is an illustration. It's now about 10 years old, but more or less remains fairly valid about the interaction between occupational agents. If they are high molecular weight, like proteins, they may be lower molecular weight, but in general, they trigger a cascade of interactions at the cellular level with T lymphocytes that differentiate into what are called Th1 or Th2, and the Th2 drives these interleukins that interact with the B cells, the B lymphocytes, eventually releasing immunoglobulins E and G, and which cause the granulation of the mast cells. So these pathways, the very classic one of the allergens, and that happens in the occupational environment, but also there is the irritant-induced one, where there is epithelial damage and oxidative stress, and there are some reactive oxygen species, neutrophilic inflammation, but somehow this pathway eventually also converges with this other one, so the manifestations may end up being similar. but the way they originate and how the cascade proceeds is different between the two. So these are the two major types of occupational asthma that are recognized: sensitizer-induced and the irritant-induced. So if we have some definitions, work-related asthma is asthma that began or worsened in relation to an environmental exposure at the workplace. The types of work-related asthma are recognized are first what is really called occupational asthma and work-exacerbated asthma. And as I mentioned, if the occupational asthma is caused by a sensitizer, there's usually a latency period between the exposure and the onset of symptoms. However, when it is irritant-induced, for example, a spill, ammonia, chlorine, an agent that is potently irritant, there's usually no latency period. It's within hours, and the patient experiences the onset of symptoms. Work-exacerbated asthma is increasingly recognized and refers to the fact of pre-existing asthma that the work environment exacerbates in a significant way. And I'll refer to that in a few. It is probably more frequent than occupational asthma, particularly in the United States. So there are a number of other conditions that are similar to asthma, and that is their status not completely, sometimes it's well understood or well studied, like in the case of cotton dust induced airway disease. That's called Silicosis, of which we see less these days in the United States, but it is seen in other parts of the country. The World Trade Center dust-associated airway diseases have some features of occupational asthma, but in some cases it differs, and I won't belabor that point right now. And organic dust has long been associated with asthma-like disorders, but they are really not, they don't completely meet all the diagnostic criteria. So they are kind of a cross between chronic bronchitis and asthma clinically. A large number of agents, more than 300, have been associated with causation of asthma in the workplace. And I just to very briefly, of course, there are more than 300, as I said, but the larger groups to remember in case of, is when there are animal or insect-derived antigens, for example, working with laboratory animals or working with casein and other proteins that are out of animal origin, they can be allergenic. Exposure to plants, woods, vegetable gum. There are many wood dusts that have been associated with occupational asthma. In industry, biological enzymes are extensively used, and I'll just give you an example. For example, in the case of the enzymes that are used to enhance detergents that are used for laundry, they used a wide variety of enzymes that were very well documented to cause occupational asthma. But in other pharmaceutical processes, they are also used. Metals, including cobalt, tungsten carbide, some metals like platinum and nickel. Pharmaceuticals. This is in the manufacturer of your, xylene, for antibiotics, etc. Amines like ethanol and ethylene amines, aromatic amines, colophony used in soldering. And there is also a mixed bag of other chemicals, usually low molecular weight ones, like isocyanates, aldehydes, chloramine, ammonia, etc. These are very important, and isocyanates, this is maybe a board eligible question. For example, using car paint spraying, these are the considered still the leading cause of occupational asthma in higher income countries, industrialized countries like in the United States and Western Europe. So isocyanates. So There are, in practice, we keep lists of these agents or use internet-based listings to try to keep track of, particularly when there is an agent that is less frequent. And but I would caution that in general, the controversy about occupational asthma relates to the fact that many of these 300 or so agents are highly infrequent or cluster in certain areas of the world. Some agents may have a mix, or the pathogenic mechanism is completely unknown. The list keeps enlarging, getting bigger and more as more irritants and sensitizers are introduced in the industry. And exposure to more than one sensitizer or irritant, it can happen in a particular workplace. So there's no sometimes one-to-one relation. Some occupations uh, 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 present the risk of exposure to more than one hazard. And it has to be admitted that some of these, the documentation for some of these associations has sometimes been limited for at least some of the agents to case reports, case series. So it has not reached the level of evidence that would be ideal to have. So it's a kind of work in progress in a way. So in the case of work-exacerbated asthma, as I mentioned, it's a different type, it's a different situation. It is when you have somebody who has a confirmed and well-known previous diagnosis of asthma that predates the entry into the particular workplace that you are investigating, and that experiences an association between asthma symptom intensity and the work situation. And usually in the form of increased symptoms or increased medication requirements in that particular occupational exposure setting. And work-exacerbated asthma is very likely more common than occupational asthma. And amongst the recognized asthma aggravating factors that you should take into account in the evaluation of your regular asthmatic patient is whether there is exposure to dust, exposure to irritant chemicals, temperature extremes, extreme heat or extreme cold. As you know, the airways are sensitive to reactivity. Uh, to those agents in the form of increased reactivity, poor indoor air quality in general, and or physically strenuous work that may trigger exercise-induced asthma, for example, in some individuals. So as I mentioned, occupational asthma is the most frequent occupational respiratory disease reported in developed or high-income countries, estimated to account for anywhere between 6 to 15% of adult onset asthma cases in developed countries. And it has a particularly high prevalence in the metal, construction, rubber, plastic work, and printing industry, and also industrial cleaning. For example, in the healthcare sector, we see it in individuals exposed to agents that are used for disinfection and sterilization, like glutaraldehyde, formaldehyde, etc. Just so you see an example that is not so far from your current occupation. So, the exposure in this country, prevalence to occupational asthma causing agent has been established, although this is literature that is now about a quarter century old, at about 8% of the working population in the United States is exposed to agents that can cause asthma. So exposure is the most important determinant in the development of occupational asthma, and that's why your history is really of paramount importance. A to B may be a risk factor, but is poorly predictive even of sensitizing-induced asthma. So that doesn't mean that an atopic individual cannot work in an environment like that. Where there is a exposure to potential occupational asthmagens. Smoking is not really so much a risk factor, but it may affect the severity of sensitizer-induced asthma. There are some studies, that suggested that, but again, it's not a deterministic association by any stretch. The same happened with bronchial hyperreactivity, and it is thought that there may be some predisposing genes. There was some investigation about a variety of them, but really nothing has been established with certainty. I won't go in detail into this scheme that goes from the initial suspicion to preliminary and confirmatory evaluation all the way to management. I only wanted to emphasize the fact that in the management of occupational asthma cases, besides the clinical approach, according to whatever the guidelines are at the moment, there has to be intervention at the level of the work environment that in most cases, particularly in sensitizer-induced cases, implies removal, because even very small amounts of the agent can cause the symptoms. And also, there are measures to try to decrease exposure. And importantly, the public health and legal implications like workers' compensation, notification of public health agencies. New York State has a reporting scheme for occupational respiratory diseases, and the notification of the employer and or coworkers as applicable. So in order to prevent further disease in this environment. I'm going to switch then to another common respiratory disease that you are very familiar with, I'm sure, with chronic obstructive pulmonary disease. Just to mention that besides tobacco and cigarette smoke, a number of other occupational dust and chemicals and indoor, outdoor, and outdoor air pollution have been recognized as contributing to the etiology of COPD throughout the world. And this particular cartoon, I should have added the credit. This actually comes straight from the GOLD guidelines for COPD. So this is a very well recognized factor that although cigarette smoke accounts for over 85% of the causation of COPD, there are a number of other contributors that can, if they are removed or controlled, could mitigate the impact of this disease on any population. And this has been documented throughout the world, not just in the United States. Again, going to the scheme, and then not to be surprised, since for COPD, as was the case for asthma, there is an interaction between host factors, environmental factors leading to inflammation. In this case, the inflammation is different from that of asthma. There is oxidative stress, probably protease, anti-protease imbalance, and a number of cellular mediated inflammatory mechanism by neutrophils, macrophages, and T lymphocyte, leading to structural changes and functional changes that are distinct from those of asthma. There is alveolar destruction in the case of COPD, not in the case of asthma. There are distal airway dilatation that's indicated and leading to eventually to emphysema, and functional changes that are lack the reversibility of asthma, and there is airflow limitation, but only with some partial or no reversibility at all. So you will review that in your lecture about COPD, but I just wanted to underscore the fact that it is very similar for the occupational counterpart. So this was a review that is already a little bit dated, but it actually hasn't lost validity. It was excellent, published in Lancet about 15 years ago, and where the authors reviewed non-smoking risk factors associated with COPD. They are listed here: indoor and outdoor air pollution, occupational exposures, and there are a variety of settings: crop farming, animal farming, dust exposures like in coal mining, in gold mining, hard rock mining, tunneling, concrete manufacturing, construction. You see all of these. Iron and steel found in chemical exposures like in plastic, textile, rubber industries, leather and food product manufacturing, and in occupational environments where there is pollutant exposure, like in transportation and trucking, automotive repair. And so those are amongst the non-smoking risk factors associated with cessation of COPD. So the population attributable risk of occupational exposures as causes of COPD, it has been estimated at about 15%, but it varies from country to country, and is being studied in some developing countries actually higher than that. At the individual level, it may be difficult to establish occupational causality for some exposures, particularly when there is co-exposure with cigarette smoking, which is not infrequent. But that in a way doesn't exclude the possibility of in fact, it may be perfectly plausible that the occupational exposures have made some contribution, and so it should not be excluded at all in somebody who has a smoking history. So achieving complete prevention of COPD, as you can appreciate, should be within reach. You know, if you remove these environmental exposures, if you lead to tobacco cessation and even prevention. I'm going to switch gears now to the pneumoconiosis, of which you may have heard, and just to give you some examples of those. Instead of airway diseases, as I've covered up to now, I'll go to more parenchymal diseases, and they are a number of disorders that are caused by inhalation of dust or fibers, and characterized by inflammatory changes that usually initiate or take place in the pulmonary interstitial space. So the disease incidence is usually proportional to dose intensity in broad terms. Relatively high dose is needed to produce disease. So usually very trivial exposures may not lead to disease. It is very common that there is a long latency between the time from the first exposure to the disease onset, and it can be of several decades, 1 to 3 decades. It's not unusual. And fibrosis is a typical common denominator of these conditions. And presently, there are no available effective treatments once interstitial fibrosis has been established. So amongst the fibrogenic minerals, dust, and fibers, I'll just mention some of the best known ones: silicon dioxide, silica, coal, dust, and carbonaceous materials. And then there's a variety of silicates, which we can divide into asbestos or asbestiform types, like asbestos itself, or the non-asbestos silicates like talc, kaolin, mica, and there are others. But these are the major fibrogenic materials. These are less frequent, and they have some very colorful names, and sometimes requires mineralogical expertise to really try to establish, and they may be silicates like these two that are listed here at the end, but they are much less frequent. And there are also some minerals that, although they deposit in the lung, they don't elicit much of a fibrogenic reaction, and the classic one is iron, that produces a very abnormal imaging studies of the chest, but actually very little lung disease, and it's siderosis. Stenosis is this a similar situation. So So let's just then move on to a few of the examples of the pneumoconiosis and the most frequent amongst them. So the coal dust lung disease or or coal workers pneumoconiosis is caused by the inhalation of coal dust and other carbonaceous compounds. So it's characterized by the formation of lung nodules and focal emphysema. And of course, it occurs in coal mining, but also in foundry work, in carbon black manufacturing. Of course, the pathogenesis involves the inhalation of the dust, the deposition of the dust at the level of the respiratory bronchioles. Those are the bronchioles, distal bronchioles that lack any cartilage and in their wall. The phagocytosis and there are alveolar ducts already branching out from them. So there's some gas exchange in some respiratory bronchioles. And that's why they are called that way. And there's this phagocytosis by alveolar macrophages and by a number of mechanisms that are not fully understood. There is activation of inflammatory mediators that eventually leads to remodeling of the lung with formation of the classic coal macules. They are in, and I'll show a micrograph in a few minutes. So there are a number of progression factors, of course, but one important one that I wanted to underscore was that the severity of coal workers pneumoconiosis actually tends to be markedly enhanced by the presence of silica in the coal dust. Because of course, as you can imagine, when you mine coal, you're not only getting coal from the coal seam, but you're also blasting the rock that is made up of quartz and silicon dioxide. And the more quartz there is in that particular mine, the more severe the disease is. Tuberculosis is a comorbidity or a complication of some of the pneumoconiosis like coal workers and silica induced lung diseases, and a factor accelerated the progression of the disease or enhancing the clinical severity. And there are, as usual, individual susceptibility factors that are not very well understood. So in the histopathology, the classic is the finding of the coal macules and nodules. They are usually the nodules are less fibrous and organized than those of silicosis. Again, I'll show some of that. And there, surrounding them, there are areas of focal emphysema and extensive deposition of dust along septal lines, but not a lot of fibrosis unless, as I said, there is silica in the deposition in the lung. And there are some variants that like progressive massive fibrosis and rheumatoid lung. So the clinical forms of coal workers pneumoconiosis is simple disease when the nodules are less than 1 centimeter, and clinically there is minimal or no functional abnormality. Complicated disease is what we call progressive massive fibrosis, and the nodules exceed 1 centimeter in diameter, and there tends to be lung function abnormalities, more so in the more severe progressive massive fibrosis. Rheumatoid cold pneumoconiosis is when there is, the nodules are usually variable, and in this particular condition, they can cavitate. That's not very common in this disease unless there's either tuberculosis or rheumatoid arthritis as a coexisting disease. And so the diagnosis, you have to document the occupational exposure. Again, the radiology is helpful, the histopathology, and as is the case with all occupational respiratory medicine, exclude competing causes of disease. So this is how a respiratory bronchiole looks when there is deposition of coal dust along in the wall, and there is already a fibrotic reaction on the wall of these respiratory bronchiole. I'm showing it here with these collagenous tissue surrounding the wall of the and deforming the respiratory bronchiole. And the macules, as in the interstitium, you see this deposit again of pigment. Of course, macroscopically, you see extensive coal dust deposition, and very. This is an X-ray that shows some nodular disease, very faint, very fuzzy, and some increased linear density, but again, generally fairly subtle. And I have here a comparison between a normal, a simple cold workers pneumoconiosis and a case with progressive massive fibrosis, where you can see what I mean with the relatively low level of abnormality in simple cold workers pneumoconiosis, and how severe it can get when these nodules start enlarging and coalescing into larger nodules, masses essentially, like these ones here. So that's what is progressive massive fibrosis. So CAT scan, of course, makes things easier in terms of recognition. And here you see some of these macules. You see how they are fuzzy. They are not sharply defined. They are less than 1 centimeter. They tend to be more in the right upper lobe, posterior predominance, and they are throughout the lung. And there is associated focal emphysema next to these nodules usually. So you see areas of emphysema. So you see how exposure to coal dust is amongst the potential causes for COPD, and you can recognize it here. But also in another CT scan, if you go more detailed, you can see areas of honeycombing, of which you will hear in your interstitial lung disease lecture, and the areas of emphysema again at the basis of the lung. You can see it there, and it's a cold workers pneumoconiosis case. In the last decade or 2 decades, there has been a sharp increase in the incidence of cold workers pneumoconiosis in the United States, and that is thought to relate primarily to deregulation, smaller mine operations, and higher content of silica in the coal seams. So all the leading in some cases to the need for lung transplant for some of these cases that are very severe. So I'll switch on that to the silica dust related lung diseases. They are caused by inhalation of crystalline silica dust, which is silicon dioxide, and is characterized by interstitial fibrosis and formation of nodules. Silica has different presentations in nature. It can be crystalline or it can be amorphous. When it's crystalline, the most common is forms are listed here, with quartz being as a particularly fibrogenic one, the same for cristobalite. A large variety of occupations involve exposure to crystalline silica, of which mining is just one of them. But remember, glass manufacturing, the manufacturing of abrasives, boiler scaling, abrasive blasting, the manufacture or use of silica fillers is used as a in many, for example, in toothpaste, if you you didn't know, is actually about 40% silica dust. So of course it's not being inhaled, so it tends not to cause any problem. But it's just so you see how even some very common products are utilize silica. So the risk is not for you as the user of toothpaste, but of the worker who is employed in the manufacturing of those products and other dental products. Silicosis is the most common occupational lung disease in developing countries. And here we have an example of why these diseases happen. This is a worker that is definitely using a hard hat, and is protecting his eyes, but certainly has no respiratory protection whatsoever for the dust that the sowing of these granite slab is produced here in this operation. So these I won't belabor the issue of the cascade, as I said, that leads to the inflammation and the fibrotic process, because I wanted to show you a little bit how it looks like it and how you can contrast it with the one with coal dust, where you see these very intense fibrogenic reaction. These are layers, onion-like layers of collagen with a cellular environment around it. But this is the intense type of reaction of the siliconic nodules. So early, you may not notice it, mostly some inflammatory cells, but they quickly develop in these very intensely fibrotic nodules. The X-ray, the radiology is again nodular disease, some linear densities, and in more severe disease or more in the complicated form of the disease, like we call dust, you see the coalescence and the formation of these masses leading to progressive massive fibrosis. So CT scan again makes it easier to recognize, and you see the nodular disease scattered throughout the lungs, right? They are harder. You see that more defined than those coal workers. And that's a case of simple silicosis, multiple nodules, less than 1 centimeter in diameter. They tend to give relatively mild symptoms that minimal or no physiologic abnormalities. And here is another case where you see again the nodular disease. There are some linear reticular opacities, and perhaps a little bit of traction bronchiectasis or bronchiectasis in the upper lobe with some loss of volume that you can appreciate better in the sagittal, in the coronal reconstruction here, where the upper lobes have lost some volume, and in fact, they pull the main stem bronchi upwards. So this is another case, simple silicosis. It was a tunnel digger, and I wanted to show you in this example because it shows how, even though it's a predominantly simple silicosis, there is already this coalescence of nodules here that eventually can progress to the larger masses that I showed you before. And one important thing, that silicosis does not produce real pleural plaques, but however, when there are subpleural nodules and they coalesce as it does here, it can produce a pattern or an image that is some people call pseudoplaques, or that suggest pleural thickening, but is due to the coalescence of parenchymal subpleurally located nodules. So this is another case of simple silicosis. It is a case of dental technician, somebody who is in the manufacturing of dental products. And there's multinodular disease with essentially minimal or trivial confluence of those nodules. So in complicated silicosis is when there have been coalesces of the long nodules into conglomerates that exceed 1 centimeter in diameter and may evolve, if severe enough, into progressive massive fibrosis. In progressive massive fibrosis, the masses are usually 2, 3 centimeters, 5 centimeters in diameter. They are really large, and usually bilateral. And so other findings in chest imaging includes These nodules are usually non-cavitated, and silicosis can cause eggshell lymph node calcification. I'm going to show you that in a moment. They are not pathognomonic of silicosis, but it's one of the most frequent causes of that particular pattern. And these masses can cause bronchovascular amputation and distortion areas of bronchiectasis and atelectasis. People tend to be fairly symptomatic. And because of the traction of the lung upwards towards the upper lobes, there are bullous changes, usually in the lower lung zones, that look like blebs, like the ones that you see in severe emphysema. But as I said, the pleural changes are usually caused by coalescence of nodules in the subpleural location. Again, this is the case of progressive massive fibrosis. You see the large diameter masses, again, intensely fibrotic in a concentric way. And here's an example of this progressive massive fibrosis and some of the subpleural nodules that can give the appearance sometimes of pleural abnormalities. Not infrequently, these masses have calcification, as you see here in these two. And also this is to show you some mediastinal and hilar lymph nodes that have the classic eggshell calcification. Sarcoidosis can also do this, but not so frequently. So, but silicosis does it a little bit more often, but again, do not expect to see this in every case of silicosis. So here, again, more cases of progressive massive fibrosis from silicosis. You see here some pleural reactive thickening, linear stranding, and traction, and more of the same, progressive massive fibrosis with conglomerates. And cavitation is not very frequent, and when you see it in the case of silicosis, you may suspect that there may be coexisting tuberculosis. You should know that silicosis is a risk factor for tuberculosis with an enhanced incidence that mimics that of HIV. Is actually quite important. In South Africa, the triple threat of HIV, tuberculosis, and silicosis is rampant, for example, amongst minors. So sometimes the PET scan can be quite active, and some of these masses sometimes are confused with cancers. This is a case that a dental factory worker that minimal smoking history and was constantly being investigated at 3 teaching hospitals in New York City for cancer, although he has bilateral disease. And as I said, was not much of a smoker, and only like 2-pack years or something like that. And he had asthma, was admitted to the ICU, and the attending in the ICU decided to take advantage of the situation of the control situation of the patient to do a needle biopsy, and demonstrated that this was silicosis. Accelerated silicosis is just a more rapid form of the disease in people who are very intensely exposed to silica. And there's also a rheumatoid variant of silica, pneumoconiosis. And in the United States, in the area of Appalachia, and in New England, in Vermont, New Hampshire, and also in the Southwest, in the mining states like Arizona, Colorado, Nevada, there tend to be more cases of silicosis than we see here. So for asbestos, I'm just going to mention that there are several patterns of disease. There can be parenchymal disease with asbestosis, pleural disease with effusion, plaques, diffuse pleural fibrosis or rounded atelectasis, or neoplastic diseases. That can be bronchogenic carcinoma or mesothelioma. So not all of them are coexistent, and in fact, they may appear separately. The majority of people may only have isolated pleural plaques and not necessarily as interstitial lung disease, which is what asbestosis is. So the term asbestosis should be reserved for the interstitial pattern of disease. And it's, asbestosis is a long latency disease. 10 to 20 years are typical, sometimes longer than that. And in a few cases, the changes may not be detected by chest radiograph, but in this day and age with CAT scans, it's really impossible to miss. And this is a CAT scan of an individual, and you see that it has a pattern that is not very dissimilar to that of interstitial pulmonary fibrosis. It has the usual interstitial pneumonia pattern with traction bronchiectasis and bronchiolectasis and reticular changes. Not so much ground glass, a little bit, but not so much. And but for all intents and purposes, it looks like interstitial pulmonary fibrosis. Some people require that there be pleural plaques as evidence of asbestos exposure, but not everybody agrees on that. So this is again the interstitial thickening in the lung with the observation of these ferruginous bodies that are fibers. Another example with the thickening of the interstitium compared to the normal alveolar walls, the ferruginous bodies that can be seen in this disease. And pleural disease in the form of thickening, and this is how it looks. And it can be calcified, you see, like this one here. All right. And again, the latency is 10 or more years of after initial exposure, usually asymptomatic, practically no evidence of functional impairment. And that's other examples like CAT scan here. They tend to be very close to the ribs, as you can observe. Can be calcified or not. And when it's diffuse, it's usually the visceral pleura that is affected. And here's a case of rounded atelectasis. It's like a swirl of pleural thickening involving the parenchyma. And again, asbestos is associated with mesothelioma and lung cancer, both. So here's just to show it's the same as the pleural plaque, but way more extensive. And you see the thickening quite significant and extensive, you know, usually not calcified. This is another example. So, and bronchogenic carcinoma. And just to remember that asbestos and cigarette smoking have a multiplicative effect on the incidence of lung cancer. So these are classic numbers from Silicosis here at Mount Sinai, where asbestos increased the risk of lung cancer by 5 in the absence of tobacco. Tobacco in the absence of asbestos increases the incidence by about 10 or 11. And then when the two of them are combined is the cross product. That's like the classic synergism in epidemiological terms. So here are the causes of occupational lung cancer. I won't have time to review them. I distributed an article with the review of the occupational lung carcinogens according to the International Agencies for Research on Cancer. And you can see that asbestos and silica are here. Some metals like beryllium and nickel, diesel exhaust, polyaromatic hydrocarbons. Nobody's going to be surprised about that. Ionizing radiation. But there are also some occupations that are, it's not very well understood exactly which agent or combination of agents is related to the causation of lung cancer, but the epidemiology is pretty clear. And on that, I'm going to close and thank you for your attention, and feel free to direct any questions that you may have.